Okay, a long time in the planning, a long time coming, but it's finally here. It's Health Talk, and I'm Peter Christian. That is John King. Good morning, John.
Good morning. What a beautiful day.
It's fantastic. But it's a better day because in the studio for the very first time is Jeff Fee. He is the CEO of Providence Health Services, Western Montana, and, of course, St. Patrick Hospital. Jeff, how you doing?
Great. Good morning, and thanks for having me.
First of all, thank you and all of the folks behind the scenes in getting all this together. I know it's been a monumental effort to bring this show on the air, and we appreciate your willingness to be on the show and talk to everybody about what's going on with healthcare in Western Montana. I know there's been so much going on. For instance, everybody's worried about the future. I mean, we all know kind of what's been going on in the past with the president's healthcare bill, all sorts of changes. Hospitals, coming and going, buying and selling. What's in the future for Missoula healthcare through your eyes?
Well, I think that certainly, I think it's still a little bit opaque in my eyes because I've never been really good at predicting the future. But I can certainly say with a high degree of confidence that when you look back, and I will have to go back for just a minute, the healthcare industry in the U.S. has gotten a lot of well-founded criticism because in a lot of respects, people don't think that we are getting the value out of our investment in healthcare. And certainly there's some very valid arguments along those lines. And I would contend that healthcare in America really is broken for a whole variety of reasons. One thing that America does best, better than anywhere else, is we have the best tertiary and quaternary care in the world. It's the reason why people from all over the world come here for really, really high-end care, whether it's open hearts, craniotomies, cancer care. What we haven't done as a nation is really invested in or built a health care system. Right now, our delivery system is really centered around sick care. And the future really is going to be more around healthcare, which is creating healthier communities, working with others that are involved, school systems, public health departments, other agencies, really in terms of looking out more proactively and trying to create true healthcare, not just really good sick care.
So what are you working at to get there? Obviously, there's a lot of ideas out there from the federal level, the state level. There's bickering and arguing, but you're stuck with the job of actually having to bring health to the people. So what are some of the ideas you guys are trying to put on the ground right now?
So let me start back again with some of the macro level incentives. I mean, right now our current incentive structure, we're in a fee-for-service arrangement, which means for every MRI we do, for every knee that we do, for every open heart surgery that we do, for every colonoscopy that we do, we get paid on a per-click basis. And there are inherent perverse incentives that are created with that economic structure. So the CMS administration, Centers for Medicare and Medicaid, have basically put a line in the sand, and they said by 2018 that they expect to have 60% of their payments revolved in some type of value-based payment. So it's not just around fee-for-service, but really getting value out of the healthcare system.
Can I ask how they judge that?
Yeah,
I mean, how do they assess value?
Yeah.
They assess value based upon a variety of factors. Obviously, at the very front of it's quality, patient experience being one of it, overall per capita costs. So, I mean, I think most of Americans just automatically expect that they're going to get high-quality health care when they enter in a healthcare delivery system. What they don't feel like they're getting is a bang for their buck. And so actually driving down the cost of care, which gets to this concept of triple aim.
Now, I want to talk about that for just a second, but you are a hospital, and it just seems like one of the things I remember listening to a lecture that you did at St. Pat's to a lot of smaller hospitals and smaller clinics, that so much care is being shifted, if you will, to smaller healthcare clinics and away from larger brick-and-mortar hospitals. So how does that affect you as St. Patrick Providence?
Well, we are more than a hospital. We have a large medical group. We employ roughly 150 plus providers right now, and the vast majority of our patient encounters actually happen in our clinic settings. They don't necessarily just happen in the hospital. The big cost, high profile encounters happen in the hospital, but the vast majority of our encounters actually happen in our clinic. So we're really switching our viewpoint of who we are away from just, we're going to always have a really good hospital. I mean, we're going to need hospitals. We're level 2 trauma center. We're going to continue to have hearts. We're going to continue to have car wrecks, and we're going to be there in terms of being able to provide really world-class hospital care. But our shift strategically really is focusing more around the continuity of care and really working and swimming upstream to actually keep patients healthy and ultimately keep them out of the hospital. And that's fundamentally why when I step back and started talking about the incentive structure, if you continue to pay the healthcare delivery system the way that you pay us today, you're not going to see any demonstrable change.
It's nice to hear the delivery system talking this way, because I think a lot of people feel or have noticed this perverse incentive structure that's built into the system. But what I want to know is, what's the timeline for the change? You had mentioned Medicare and Medicaid by 2018, was it?
Correct.
So is that going to broaden to other consumers that are non-Medicare and Medicaid? And when does Providence plan on implementing the value fee system?
So that's a great question. And I would like to think that it would be more aggressive in terms of the timeline than I think the reality of it is. I'd like to say 5 to 7 years. The reality of it probably more closer to 10 years. We are working in partnership with our payers as well. So Blue Cross Blue Shield, Allegiance, they've been great partners in working with us and actually starting to develop pilot programs to start paying us differently. And so we're going to be, and it's one of those things you've got to be careful how you bridge the gap, because ultimately, the future state where the healthcare delivery system is held accountable clinically and economically for an attributed patient population is something that we want to see happen. Because then when you think about the macro level economics, in today's environment, my leading economic indicator of success is how many patients I have in the hospital. In the future, it's how many patients I've successfully kept out of the hospital. Not because we're taking better care of them in the outpatient setting, in their homes. Because there are a lot of avoidable hospitalizations that happen in today's environment because we don't have the infrastructure on the ambulatory setting.
We're up against a break.
Sure.
When we come back, I want to talk about AAA, because you hit a new term that I had not heard before, and we'll talk about that when we come back. Telephone lines are open, 721-1290. Our guest is Jeff Fee. He's the CEO of Providence Health and Services in Western Montana.
That went quick.
And we are back on Health Talk. It's a brand new segment here on Talk Back. It's sponsored by Providence Health and Services in Western Montana. Jeff Fee, CEO, is joining us. And you introduced a brand new topic, a new term that I had not heard before, called triple aim. What is that?
The triple aim is exactly what we as a delivery system are trying to do. And I think there's a lot of different factors in the healthcare industry that are trying to accomplish the triple aim. The triple aim is improving the quality of care, improving the experience of care, and while doing both of those, lowering the overall per capita cost of care.
Okay, now you just hit on something that I think is at the bottom of everybody's experience, and that is lowering the cost of care. Because everybody I've ever heard, whether it's a politician or a healthcare provider or whatever, always talks about the number one problem in healthcare is the actual cost. So, first of all, perhaps as a hospital administrator, you can help explain where do the costs come from? And I know that many times people come into St. Pat's or any other, hospital at the end of the emergency room and they can't pay for their care, but you are required by law to serve them. So who pays for that?
Well, we do. I mean, the fact of the matter is people that show up in the hospital that don't have any type of coverage, there's this dirty little term in the healthcare industry called cost shifting. And it's ultimately, if we don't cover the cost of care because someone hasn't been able to pay for their cost of care, we shift that cost burden to those of us that ultimately are out there working, that have insurance. And that's one of the reasons why we've seen double-digit increases in premiums on the private sector side for years and years. Okay, and so what is your organization doing to try to, in the overall effort, to try to help bring those costs down? Well, that's, again, it gets back to this overall macroeconomic conversation around incentives. And in today's environment, the factors around why healthcare is so expensive, I mean, that's a day-long conversation. Yeah. It's very, very complex. But one of the biggest factors is the perverse incentives created by a fee-for-service environment.
We've mentioned that a couple times. Can you just lay out for the listener, what do you see as some of the perverse incentives? One that comes to me in my mind is, you get paid more as a hospital if you keep people in the hospital longer.
Actually, most of our payments when it comes to inpatient work We're moving very quickly towards actually having a fixed payment. So there's actually an incentive for Medicare. They're under a DRG, which is a diagnostic related group, which says, if you have congestive heart failure, this is what you're going to get paid. And so there's actually an incentive to aggressively manage that care and get the patient out of the hospital as quickly as we can.
Gotcha. So what do you see as some of the perverse incentives in the current system?
Well, so when I was back in Tennessee, we had on one road 8 MRIs.
Whew.
8 MRIs could have serviced the entire population of Chattanooga and its major metropolitan service area. Blue Cross Blue Shield of Tennessee did a study that and this isn't a negative comment. It's just it's a statement of how the current economic structure creates perverse incentives. That if a provider owned an ancillary piece of equipment, utilization of that piece of equipment went up by 33%.
Wow.
So what happens is oftentimes a physician goes to school for years and years, and quite frankly, I want the best and the brightest going into medicine, and we should pay them appropriately. We don't want to create perverse economic incentives for people going into healthcare. What ends up happening is no one wants to make less next year than they made this year. And so what happens oftentimes if a payer cuts a physician fee schedule, what's the physician's incentive? To do more, right? So they make the same. So it's that doing more. One of the biggest factors of the cost of care in America is the doing more phenomenon. The more we do, the better we get paid. We've got to shift that to, there's a lot of inappropriate stuff. And quite frankly, when you look at our part of the world, we're considered well managed. You go to other parts of the U.S. where there's more of a churn and burn mentality, the cost of care is completely out of whack. So my contention is until you fundamentally change the incentive structure, you're not going to get meaningful change in the actual delivery system. How
much of the fee structure and the overall cost that you're talking about are enveloped in the whole legal system? With I know there's been all sorts of cries for let's try to revise the whole medical lawsuit malpractice thing. So is that built in because of what's going on in the legal community?
Defensive medicine is clearly another factor that contributes to the cost of the high cost of care in the U.S. The fact of the matter is we've got very, very good, well-intentioned physicians, and the simple threat of a lawsuit might incentivize them to do some extra tests that may not even be clinically indicated. But if they don't do those tests and something happens on the back end, right, they're completely exposed. Right. And I do think that there is definite need for some malpractice reform.
So it seems to me like the two of the things that you listed as negative incentives were driving towards more testing and more use of equipment and more cost on that end. But it seems to me there's also a risk that if you don't do enough, right, that you don't quite get there and that the person doesn't get healthy because the cancer doesn't get screened or something. So how do you find the proper way to walk that tightrope without going off either edge?
Again, this may be an overly simplistic assertion, but I think that if we do a better job really on the front lines in primary care of knowing our patients more intimately, being very educated around where our patients are at risk. Somebody like myself, low risk, I'm at high risk of probably injuring myself skiing, but not necessarily from developing some type of chronic disease. But the people that are about ready to have a chronic disease, we got to be better at being able to predict who those people are. And there's mechanisms that you can use to actually that you can go in, stratify your patient population, your patient panel, and get out and really work with and know those patients so that ultimately you swim upstream and you avoid having to do some of those high-end tests because you're managing them more aggressively in the outpatient setting.
Isn't that what the medical home concept is all about?
That's exactly what the medical home concept's about.
Okay.
Yes.
Could you just kind of explain that real quick?
Well, the medical home is basically a concept. It's a medical home for a patient where the patient is in the center of care. You have a physician and a team of providers, whether they're mid-levels, social workers, pharmacists, nutritionists, that work together as a team to manage the health of a patient. And the success of the medical home on the economic front is managing those that need to be managed and staying in touch with those that just need to be stayed in touch with. Because ultimately there are varying degrees of care that are needed based upon the individual patient's needs and demands. So it's being able to scale the care, up and scale it down depending upon the patient need.
At what point does that become intrusive to the patient, or is that something that you and the patient work out, where you say, we're going to be calling you once every 3 weeks, once a month, depending upon the seriousness of your condition, just to check up and make sure you're okay?
Yeah, it's never intended to be intrusive, and I don't think we have ever encountered, when you really come at it from a position of compassion, that we are truly caring for you as a human being, and we want you to be well. We want you to feel better. People respond almost 99% of the time very positive to that. How you do that is obviously somewhat of an art form.
We're going to come right back. Jeff Fee is with us. He's the CEO of Providence Health and Services, Western Montana. This is the inaugural edition of Health Talk, and we'll be right back. As it often happens, the half hour just flies by, and Jeff Fee joining us here in the studio this morning, and we are talking, this is the inaugural edition of Health Talk, and one question we haven't covered yet is, let's talk about in the terms of health of our people, where does Montana stack up?
So there's a organization out there called americashealthrankings.org. I encourage you to go out and actually look at their website, and you can see ultimately how every state in the union stacks up relative to health care on several different really key health measures. Currently, Montana is ranked 22nd in the U.S. We have some positions of strength in terms of air quality is one of the strong ones. We actually, from a national perspective, we're low in the BMI, body mass index scale. We're atrociously poor performing in areas like childhood and adolescent immunizations, where we rank 45th and 44th in the nation, respectively. And so it gives us a macroeconomic level challenge of really how we address healthcare for our communities. Which
is a good lead into the fact that this is going to be a weekly program, and we appreciate the fact that Providence and Health and Services in Western Montana is going to be providing people to come in every week to talk about these issues, right?
That's correct. Everything from issues associated with births all the way through, I'm not kidding, all the way through really, really complex issues around death and dying and end-of-life care.
Wow. Palliative care, that sort of thing. I'm sure we'll talk about heart issues and all the other stuff in the coming weeks.
Well, for instance, we just had a huge screening at St. Patrick's. I went and got screened, and I'm outrageously healthy. Ridiculously, considering the horrible diet that I eat, and so we'll have people on talking about diabetes, stroke, and heart disease, and all those things as the time goes on.
That's exactly right, and we look forward to feedback from the community as to other topics that the general public would like to hear about.
I'm curious what you've put your finger on as some of the issues that affect Montana as a region. Obviously, you had mentioned obesity were okay, but other things like immunization were lower. What things stand out to you as things that we need to address in our communities?
Access to primary care, access to affordable health care insurance, preventable preventable hospitalizations. Immunizations are the four that we as an organization have really identified as areas that if we move the needle on those particular items, it will actually improve the health of the community that we serve here in Western Montana.
Jeff, we are out of time. Thanks so much for being with us.
Thanks for having us, and look forward to the series.
You bet. We love having you back anytime you'd like to come on.
Great.
Thank you.
Thank you.
All right. Jeff Fee, he's the CEO of Providence Health and Services, Western Montana. This has been the inaugural edition of a brand new program, ladies and gentlemen. You were here for the birth, so to speak, of Health Talk, and it was a successful delivery. And we're